Assalamualaikum and a very good morning. I'm Dr. Shahridan Fathil. I'll be talking on management of prone ventilation for both spontaneous and mechanical ventilation. I'm not an expert. I have ventilated prone patients, COVID prone patients, but I've also been reading around, and I think we can do better in terms of how we manage the technicalities of proning patient. There is enough evidence in the literature to actually guide us. For the spontaneously breathing COVID-19 pneumonia patients, prone positioning has actually been shown to improve the oxygenation of patients and outcome of patients as well. In this particular Lancet study, it was the group of Italian authors which they've studied about 49 patients, and they've actually shown, if I could point here with the pointer, the difference. For example, the pH of patients when they are on a supine position, and then when they are prone, after about 10 minutes or so, you can see there's a marked improvement of the PaO2, and later when the patient is put back in the supine position. So even in this particular small study, the patients, the spontaneously breathing patients, do improve when they are actually in a prone position. Surprisingly, the patients in this study group, majority of them were actually put on the helmet CPAP rather than what we are used to, which is the high flow nasal cannula. For the mechanically ventilated COVID-19 patients, there is actually enough evidence to suggest that prone ventilation improves the gas exchange as well as outcome in the majority of patients. I'm just quoting this particular study of 1,000 patients. From baseline, this is a graph, the PF ratio. Definitely there is marked significant improvement when the patient is put in a prone position, and somewhat the PF ratio does go down to a certain degree, though not back to baseline after the patient is put back in the supine position. So as a take-home message, the prone position does work for the mechanically ventilated COVID pneumonia patients. How do we prone the patient in the conscious spontaneously ventilating patient? So I'm using this resource from Intensive Care Society. So if you could you could look at the flow. The first, I would say, criteria for us to consider managing patient in awake prone is where the patient is requiring a higher FiO2 and the saturation of the patient is 92 to 96%. And of course, this is in patients who are suspected or confirmed COVID-19. When we have decided to do so, there's a lot of communication that needs to be done with the patient, because the patient needs to be very cooperative. And of course, the patient needs to do this independently with no airway issues. And once this is done, we need to consider the absolute contraindications and relative contraindications. I'm not going to mention them one by one, but just to highlight some of the absolute contraindications, they are in severe respiratory distress. For example, the criteria given here: respiratory rate 35, PaCO2 of 6.5. When there is impending need for intubation, of course, I think this is probably not wise for us to do to try awake prone as a rescue at this particular juncture. And of course, when there is hemodynamic instability, agitation, and so on and so forth. In order for us to assist the patient, we need, of course, to get a buy-in from the patient, to explain the procedure, the benefit to the patient, ensure that the current oxygen therapy, be it nasal prong, oxygen mask, or high flow nasal cannula, or even a helmet CPAP is secured, and the length of the tubing is adequate for the patient to move, and then pillows to support, reverse Trendelenburg, and of course continuous oxygen monitoring. If the patient was on sedation, the sedation must be stopped for the patient to be able to actually be awake enough to move him or herself. So when this is done, we need to monitor the oxygen saturation level. Of course, ideally that it should be continuous, but if it's not available, if continuous SpO2 monitoring is not available, so every 15 minutes is actually quite adequate. So this is when you decide if the SATs is about 92, 96, and on the left, and if it's not, then you go on the right. So if it's maintaining 92, 96% with no obvious distress, so you continue in that position, and you change the positioning every hour or two, aiming a prone time as long as possible. We will get that in the next few slides. But if there's any deterioration, of course, you need to check whether the oxygen is connected, check the FiO2. You may want to change the position of the patient. But if you think that there is no improvement and the patient is unable to tolerate, or the patient looks distressed, this is where you probably want to discontinue and may want to consider invasive ventilation at this point. When the patient is in an awake, prone, spontaneously breathing, it's good to keep them in a prone position as long as possible. But of course, patients will not probably be very comfortable if they're kept for too long. So this is the suggested time position changes. So 30 minutes to 20 minutes in a prone position, bed flat, and change to the right lateral, bed flat, and then a sitting up position by adjusting the head of the bed about 30 to 60 degrees, and then later turning to the left side with the bed flat for about 30 minutes to 2 hours, and then finally coming back to prone again. So repeat this cycle so that the patient is not too uncomfortable for as long as possible. The Intensive Care Society also published this particular guideline for prone position for the mechanically ventilated patients, but surprisingly it was actually published in 2009 before the COVID pandemic. So I think in terms of indications as listed below, so when there is a significant drop in PF ratio of about 150, in terms of it is when to do it, it's probably ideal to do it in the first 48 hours and following for about 12 to 24 hours of mechanical ventilation. And the best outcome is achieved with the same ARDS principles, that you do not ventilate with too large a tidal volume, 6 mils per kilogram of body weight. So these are the absolute and relative contraindications. Because this guideline was actually published before the COVID, and it's not specific for COVID-19. See, there's a long list of the contraindications. I think in most situations, probably one of the things that we are concerned is when the patient is morbidly obese, because this may create a lot of issues with ventilation, pressure source, and of course when the patient is pregnant. And if the patient is hemodynamically unstable and requiring inotropes, so this is something that you may want to not actually embark on. Okay, these items are listed as the equipment necessary. It's I've actually seen actually assisted in the proning of patients, but none of it as I probably mentioned earlier, as how it is suggested in this Intensive Care Society guideline, which is, I think, quite efficient. This is something that I think we should consider when we are doing it. So things that we need is actually 2 bed sheets as well as 3 to 5 pillows, and of course you need to secure your ETT have some slide sheets, absorbent pad or Inco sheets, we call it in Malaysia. So this is the thing that we need to have readily available before we actually prone the patient. For the preparation, of course, when the decision is made, there should be some degree of discussion. If it is an open ICU, of course, there's going to be discussion with the multidisciplinary team with the potential risks and benefits, and of course ensure that there is no contraindication. Inform and counsel the relatives, inform other team members, and ensure that there are enough staff to perform the maneuvers safely. And consider if there is any outstanding investigations, procedures, or other necessary transfers that would prove to be difficult to perform when the patient is prone. With regards to the airway and breathing, the difficult airway training need to be handy nearby. We need to take note of what the airway was with regards to the previous intubation, the laryngoscopy, and whether there was any difficulty in the intubation. Secure the ETT, and something that you need to consider is that you need to put paddings on tape or whatever devices that you use to secure the ETT. Suction the airway prior to the procedure. A closed circuit suctioning should be available, and working throughout the procedure. Pre-oxygenate the patient, this is important, and ensure that the appropriate settings are being put on. It's also important to perform pre-proning blood gas and document the results. The lines, peripheral, central, as well as arterial lines should be secured. Discontinue non-essential infusions. For example, when there are too many drips or medication which is non-essential during the actual proning procedure, we need to stop it and disconnect it. And the patient should be cardiovascularly stable, okay, and not requiring, I would say, very high inotropes is one of the contraindications, as we discussed earlier. The patient should be adequately sedated. A RASS of -5 is considered a prerequisite. Also consider muscle relaxation. Of course, a bolus may be required. Document the skin integrity of the anterior part of the body, because something that you want to actually use to I would say to avoid any medical legal issues. Eyes should be clean, lubricated, taped to prevent drying and ulceration. As listed, all the lines should be secured. So NG feed should be stopped, spigoted. Document the NG length. Test drain should be well secured as well. And there should be a separate member of the team to manage this. Only clamp if it deems safe. Adequate length of the lines should be ensured to avoid any issues with the line coming off or being pulled, as the urinary catheter should also be spigoted and taped to the leg. And it's best to actually perform all this hygiene procedures, mouth washing, changing of the stoma bags before the prone position, because access will be an issue once the patient is prone. And keep the ventilator as close to the patient as possible. And when you prone, the patient should be turned towards the ventilator. So there should be a minimum of 5, but reckon if we have an obese patient and with the sizes of our female nurses, we definitely need more than 5. This is a suggestion by the Intensive Care Society, and if you look at the slides, they are quite able-bodied male in doing this procedure. So basically, when we do this, the team members should be well aware of who is who, There should be a team leader. The airway doctor is positioned at the head to secure the airway during this maneuver. Two staff on each side of the patient, and additional staff, particularly in the management of chest strain and of course ECMO, which we probably don't do in Malaysia. Okay, patient should be laid flat in the bed in neutral position, and then if you the arm is closest to the ventilator is tucked underneath, and you can see underneath the buttock with the palm facing anteriorly. And of course, the ECG leads anteriorly is removed. We'll place them later behind, and the pillows will be placed over the chest, iliac crest, and knee. This is how you place the pillows on the chest, the pelvis, as well as the knee. So minimum 3, a maximum of about 5. The clean bed sheet is put on top of the patient, and the edges of the bottom and top bed sheets are tightly roll up together, so kind of enveloping or encasing the patient as shown in the diagram. If the patient is moved horizontally, this is away from the ventilator at this point before turning the patient. So at this point, the patient is turned on the lateral side. So the staff on either side holding tightly on the sheets and turning the patient 90 degrees. This is done on the call of the person on the head end. So finally, on the call of the person on the head end, the patient from 90 degrees is rolled onto the prone position. So the staff on both sides is still holding tightly on the sheets, and finally rolling the patient over on the prone position. So at this point, the person on the head end should ensure that the ETT is not king. There's CO2 tracing available on the capnograph, and reattach the ECG leads and ensure that all monitoring is re-established. Okay, when the patient is prone, at this point, the bed sheet behind the patient is taken off. The absorbent pad is placed under the sheet, so the patient is being put in the swimmer's position, so the head slightly tilted to or turned to the left. The upper limb is brought up forward, so the shoulder is abducted about 80 degrees, whereas the elbow is flexed about 90 degrees, and the other hand is actually on the side of the patient. And the patient is nursed at about 90 degrees in a reverse Trendelenburg position. So as a final part of the procedure, all the pressure points should be checked. So basically no pressures on the eye. The ETT is not being kinked or pressed on the corner of the mouth. The NG tube is not pressed on the nostrils. The male private part is hanging between the legs and not pressed by the pillows, and the lines are not pressed against the skin. From prone to supine, similar steps and how we did it initially should be taken. Preparation, adequate team members, pre-oxygenation, ensuring the lines are secured, discontinue all non-essential infusions, all the catheters are spigoted, adequate sedation and relaxation before attempting to turn the patient back to the supine position. These are some of the emergencies that we may encounter in the prone position. Just to highlight 2 points here, the CPR can be commenced in a prone position, and if there's any possible distortion of the ETT, we may manage the patient by inserting a supraglottic airway. It is suggested in this guideline to use iGel, which is quite common in the UK. Personally, I feel that probably a supreme LMA would be a better choice in our Asian population. There have been no documentation to the best of my ability to look at the literature of emergency supraglottic airway insertion in a COVID-prone patient. Thank you all for the kind attention. Kita jaga kita. Thank you for being the frontliner at the last line of defense. Thank you again.
Are there any maximum time for which we can prone a patient?
I think the issue is usually about the complications of prone position, particularly when the patients are awake prone. When they are uncomfortable, they will try to get them to move around. So that's usually not so much an issue. But when you are when someone is sedated and possibly paralyzed, it's something that you may want to. I think in the literature there's nothing really solid, but most people will take it 24 hours to up to 48 hours is something maximum. Of course, the whole idea is that when you are in a prone position, everything needs to be padded. The issue is usually about tissue necrosis. Necrosis. I've seen necrosis of the mouth, necrosis of certain areas of the abdomen. So this is something that you really want to be careful of. But I think in most situations, probably a cutoff point of 24 hours would probably be appropriate. The concern is mainly, of course, when you prone them. In this, we're talking about mechanically ventilated, and everything is all right. That's fine, but the tissue necrosis is something of an issue, and you don't want to end up with a patient who you manage to survive ICU, but with a lot of tissue necrosis on the face.
Yeah, I think generally in our practice, we prone at least 16 hours because that's based on what's recommended by the PROSIVA trial, but that was for non-COVID patients. But I think actually they are more concerned how many times can we prone a patient, because certain patients, right, after we supine back, then their oxygenation is poor again. So is there a maximum number of times for which you will consider prone, or we can just continue to prone as long as there's no complication like what you've mentioned earlier?
I don't know to that answer really. Whether there's any actually a maximum number of prone.
Yeah, but I think from my hospital, we usually don't prone if, let's say, the patient already reached beyond 17 days, because we think that beyond that, the patient might not likely respond to proning anyway, because the lung would have been fibrotic, right? Yeah. Okay. Then
I just like to chip in on that. Yeah, I would agree with you. I think at the end of the day, what is your clinical endpoint that you want to achieve? Obviously, with prone positioning, what you want to do during that time is maintain the oxygenation, so the other organs and giving chance for the either still inflamed of lung tissues to recover. But after some time, as you mentioned, if it's fibrotic and if it's possible to get another CT, depends on where your facility is, your ICU is, and how easy to get your CT and stability, then you would know. Because at certain times it's just futile. Whatever you turn, sometimes you turn, it makes it worse. I've had patients when we turn, then after that patient collapse, it's not a laughing matter, but it happens. We think it improved. So it is an overall plan of what we really want and to set our limits. How far are we going? And currently, the current condition that we're having now, we are pressured for beds. So these decisions have to be made fast. How long we would like to do that. If we can't, then it's just futile, and we should reserve these resources for the next patients we are waiting in the emergency department. That is my opinion.
Yeah, I totally agree with you, Dr. Marcus. Yeah, because at one point we have to decide what is the endpoint that we want to achieve. So actually that was the next question that was posted by our participant, because they asked that how do you know that prone is actually working, and what are the parameters to look for to decide that we should actually supine back the patient?
I think it's all about the whole idea is oxygenation as well as ventilation of the patient. So improvement, we are hoping that when patient is in prone position, that the oxygenation improve. There may be a small group of patients which of course will not improve, and in like Mafi saying will worsen the condition, particularly hemodynamically. So these are the patients where you want to probably stop short and deprone them back. But it's all about oxygenation. So if there is actually improvement of oxygenation, we keep the patient in that prone position until we decide, depending on what the cutoff limit, 18 hours or 24 hours.
I've personally encountered a few cases where we have to supine back the patient because there was a lot of CO2 retention. Because when we prone the patient, then we cannot achieve adequate minute ventilation. Then there's CO2 retention to the point where patient was hemodynamically unstable and there was severe respiratory acidosis. Just recently, I had one case like that. So we had no choice but to point back the patient because otherwise, at the expense of oxygenation, you cannot just sacrifice on the CO2 as well. I guess that's my take on it. Okay. Another very interesting question. Someone said that we see many extensive subcutaneous emphysema in our ventilated COVID patients. Is there any benefit of inserting chest tube in those events if X-ray does not show any pneumothorax?
I don't know the answer to that question. Another thing, when you have subcutaneous emphysema, you cannot do lung ultrasound. So because air is the enemy of ultrasound, so definitely, there's no point. But
I think in our previous discussion, I did say that I actually saw a lot of patients with subcutaneous emphysema where eventually to assess the fluid status, have to go the subconstant 4-chamber view because on the apical 4-chamber and parasternal view, I totally cannot see anything. Yeah. So Dr. Martin, do you have any?
This is a particular problem. Like currently when we see, and these patients are the patients that actually we missed in the sense of when they became hypoxic, when they have hypoxia, we did not recognize them early. So it's when they're in the late stage. That's why I think it's one thing important when we talk about lung protective strategy in COVID patients, it's not just about when it's ventilated. It's when it's even pre-mechanical ventilated. That's why the identification of the desaturation is important because every time the lung desaturates, how in COVID-19, the lung react differently. How they will appear, that's why patient is okay because your respiratory rate is normal, almost normal. But if you really observe this patient, if you are in the medical ward, you realize they will breathe in very large tidal volume. And this is where the damage to the lung happens early, which we do not detect because they do not show us. It's only that desaturation we see. But if you take the ABG, then only you will realize. But yeah, this is the often we miss, and that's when they are starting to having damages to their lung because of that wide respiration. They give this very high tidal volumes and they breathe. And this is why some patients you will get, if you notice in some patients when you intubate, even pre-intubation, there's already some pneumothorax. And you get even sub-emphysema before because the lung damage has happened before. That's why oxygen therapy must start early, must be identified early. I mean, that's what in terms of the physiology, pathophysiology of COVID-19.
Yeah, actually, it's actually quite appalling because I think these few weeks we had patients who were not, previously we thought that it was because of our ventilation that caused the patient to have subcutaneous emphysema or pneumomediastinum. But recently we have a lot of patients who have not been intubated, but just on high flow nasal cannula. And when we send the patient for CTPA, we actually see that the patient already has subcutaneous emphysema as well as pneumomediastinum, which we cannot explain because we are not giving any positive pressure ventilation to these patients, but they do develop that.
Correct. It's because of that lung protective strategy. Even in ICU, or we have to think it that way. That means the extent of care looking at this patient is even at the Cat 3 when they are developing to Cat 4. So this type, because this is how in COVID, because the blunting of the normal reaction of tachypnea and this happy hypoxic. So this is when the damage happens. So I guess if we can identify that early, you can initiate oxygen therapy early, you can help to compensate and ensure that the lung doesn't overwork to compensate. I believe that's the, if you're really into the literature, they're actually talking about this at the moment.
Okay. All right. I think we have time for 2 more questions. So Dr. Shahridan, you say if patients do not respond to the first prone, would you recommend proning for the second time?
Probably not.
Probably not.
Unless unless there's new findings and things like some sample that can move from one subphenotype to another phenotype. That if there's evidence for that, then I may consider. But if it's the same, I don't see that's a point to actually do it again. Yeah.